I think helping patients choose what treatment might be best for them in the newly diagnosed multiple myeloma patient, it's important to kind of explain to them why we have two main regimens that we use. So one would be KRD, which is carfilzomib, lenalidomide, dexamethasone, and the other one is RVD, which would be lenalidomide, bortezomib, and dexamethasone. So I think those two regimens have a lot of data behind them and are our frontline options. So I think it's important to let patients know that that's what's recommended and that's how we tend to practice. And then as far as relapses go, I think the important thing is not to focus on the relapse, but where we go from here. I think it's important to kind of figure out what is important to the patients. First of all, do they have high risk or low risk disease? And then secondly, how did they tolerate those induction regimens? So if they tolerated lenalidomide, for example, without difficulty, then typically we would add in daratumumab, lenalidomide, and dexamethasone for first relapse. But maybe they did not tolerate lenalidomide well, so we would substitute for pomalidomide. So it would be daratumumab, pomalidomide, and dexamethasone. Occasionally, I've had patients bring to me, maybe this is a new medication that's been approved and I'm interested in taking. So we want them to know that we support and consider their decision as well as far as moving forward.
For a myeloma patient in that first relapse, especially after a transplant, they may have gone a long period of time, years possibly, before they have that relapse. So it's different from when you were newly diagnosed, and it's also different than when you were relapsed refractory. It can be very traumatic for that patient, especially if they've gone a long time. So we may have seen them in a biochemical relapse for a while, and that biochemical relapse is when we start to see some movement with the numbers, but we don't immediately make a change. So we're going to follow that. We're going to look at the rate of change. Is it starting to cause them any symptoms? And typically, when you get to a point, you'll restage that patient. So hopefully you've been having that conversation with your patient, but they still can be very surprised. So we're going to go back and again, restage them. We're going to look at, are there any new risk factors that we didn't know about? We always want to know any side effects that they've developed over time from their prior therapy. And then we look at the type of relapse that they're having. If it's that slow new disease, coming back that's not causing a lot of problems, then we may not need to go as aggressive with the regimen. And at our institution, we have an algorithm, but you still have choices in what you can choose for your patient. So you're really going to be looking at the type of relapse, the risk factors involved, what their last therapy was, and you've got lots of options. And it's sitting down and having a conversation with that patient, explaining where we are, why we're changing therapy, working with them on what suits them the best, on whether they're going to need to come to the infusion center or whether we can do an oral regimen. And it's a lot of reinforcement for some of these patients. It's like going back to that first time for them, except this time they understand what myeloma is.
From a pharmacist perspective, in terms of counseling patients on their therapy options in the induction and the relapse setting, I tend to wait until the provider and the patient have kind of decided on what treatment they want to move forward with, just because I feel like giving them the entire counseling session on all of their different possible options would be very overwhelming for the patient. So I wait until that decision has been made, and then I go into the room or call them on the phone and provide a more detailed counseling session on the medications, what their calendar is going to look like, and what the next steps are going to be. But I think I wait until that decision has been made.
Kathryn and I happen to work together, so we have a multidisciplinary team. So in our clinic, we'll have a physician, we have an advanced practice provider, we have our clinical pharmacist and nursing. But we typically, we've discussed it amongst each other frequently before one of us, whether it's the physician or the advanced practice, sees the patient to present a new plan. So if I'm seeing the patient and I'm presenting a new plan, then I will do that. piece of it. And for some patients, sometimes the physician will also come in, and then if we can, then we will have our pharmacist go in as well to talk more in depth about that change of plan. And then we like to provide our patients handouts so they have that opportunity as well to go home and read a little bit more about it, and then they can come back with questions.
Counseling for patients regarding new treatment regimens is a team-based approach where I work. So usually either the advanced practice provider or the physician will go into the room and discuss with the patient what the options might be, and then see what the patient decides. And then from that point, it is the provider's responsibility to begin the teaching about the regimen. And then we have some reinforcement with our clinical pharmacist who's in the multiple myeloma clinic. And then the nurses also help provide some guidance with medication calendars. And our nurse navigators and financial team can help if there's any cost issues or concerns for the patient. So it's really a team-based approach with multiple people kind of supporting the patient.
I think having multiple people tell the patient the same information is very helpful, just because I think that they often don't hear it the first, second, or third time that they've been told it. So having multiple people tell the patient the same information, I think, is very valuable.
I agree with you.